Our next section is cerebrovascular accident, stroke, one of the top 3 causes of death. This is what you call your absolutely must-know section of neurology. This is what you call don't walk into this test unless you know what are the top 5 causes of stroke, what's the best initial test, what's the most accurate test, and what's the therapies. Now, neurology used to be a specialty which was known for all diagnostics and physical exam and no therapeutics. Not true anymore. There used to be diagnose and adios. However, there's a lot of therapy now, and it's changing. So this is a must-know section, the stroke. Now, the first thing about stroke is that here on our first slide, you see ischemic and hemorrhagic. Now, 80% of strokes are ischemic in nature. Only 20% are hemorrhagic. Now, it's kind of silly to say large artery, small artery, because it's saying, well, large artery, ischemic. Well, if you have an embolus, and you're throwing something up from the heart, if you have an embolus and it's throwing up from the heart, where is the embolus going to go to more? A large artery or a small artery? The answer is the large artery, because there's more surface area to catch it. 2 fishermen go out. One's got a small net and one's got a large net. What's going to catch more fish? The large net. Vascular dissection is extremely rare in the brain. And systemic hypotension causes a stroke, usually in people who already have underlying cerebrovascular disease. I have a narrowed artery in my brain, the blood pressure goes down, the narrowed artery starves the brain more, and it infarcts and I die. Hemorrhagic strokes is only 20%. However, the reason why it's so dramatic is because essentially there's no therapy. Once you have a hemorrhagic stroke, there's very little that you can do to reverse it. If you drain out the blood, it'll continue to bleed more. An artery pops. That's what we call hemorrhage and rupture of a blood vessel, but we call pop here. Okay, our first syndrome here is least common syndrome. The middle cerebral is really the most common. The middle cerebral is the most common because this is a large vessel. But let's look at the other syndromes, okay? Anterior cerebral artery. Anterior cerebral artery goes to your frontal lobes. Well, what's going on in your frontal lobes? Well, I don't know what's going on in your frontal lobes, but my frontal lobes are roughly the place in my body that I call me. It's home, I like to think, to my thoughts, my personality, my charming individual idiosyncrasies and characteristics. So that means if I stroke out my anterior circulation, I'm going to get cognitive problems because I think with my frontal lobes, and my frontal lobes are anterior. That means I'm going to get confusion because I think with my frontal lobes and my frontal lobes are anterior. I'm going to get cognitive problems, behavioral problems, the ability to perform problems, anterior. Now, the anterior cerebral artery aneurysms as well as strokes will cause cognitive dysfunction, behavioral problems, but the other part of them is they're going to cause more problems in the leg than in the arm. Okay? More problems in the leg than in the arm in terms of sensory. So what happens is that they want to kick you, but they can't kick you, so instead they pee on you. Incontinence. They want to kick you, but the problem is greater in the leg than in the arm, so I can't kick you, so I urinate on you. I'm confused, I want to kick you, but I pee on you. And that is anterior cerebral artery, and that's all you have to know about it. Now, our next slide here, with the middle cerebral, this is the big event of the day. And the big event of the day is the middle cerebral artery, because what happens is that the opposite side gets weak. You basically get weakness of the opposite side, of the contralateral side, contralateral weakness, contralateral sensory, contralateral weakness, contralateral sensory. Now, what about this issue with the homonymous hemianopsia? Now, the homonymous hemianopsia is a pain in the butt type of terminology, but it basically goes like this. If this is your 2 eyeballs and their receptive epithelium, if your 2 eyeballs and your receptive epithelium, what happens is that everything that you see on this side goes through the optic chiasm and goes back around to the visual cortex back here. And on this side, it goes into the optic chiasm, it goes around, it goes around and goes into the visual cortex back here. Now, what happens is that, so everything that you see on this side, everything that you see over here, okay, on the right visual field, becomes perceived by this tract here and this tract over here. But this one on the interior decussates and goes around over here. So what happens is that if I have a stroke, on the left-hand side of my brain, if I have a stroke on the left-hand side of my brain, it means I have lost this optic tract. I can't see an object on the right-hand side because the right-hand side object is being perceived over here. I can't see the right-hand side. And what's happening over here is that this part of the retina is perceiving also to the right. So what's happening is that you're losing the right visual field. Your right visual field. So the way the world looks like to someone through their eyes is that this is what their eyes look like to you. They basically have lost the right visual field and they can't see the right-hand side of everything. They've lost the right visual field and they cannot see the right-hand side. So if you're looking somewhere, you don't know you've had a stroke. You don't know that the left optic tract has been cut. The left optic tract and radiation has been cut. Because these things decussate. They decussate. They cross. $5 word for cross. So what ends up happening is if I have a lesion and I have cut this left optic tract over here, what ends up happening is I can't see the right side of the world. Each eye is missing the right side. Well, why does the eye deviate to the left? Because if I can't see the right side, I'm no longer seeing this half of my world. I don't see it. It doesn't exist for me. So where do I look? I look to the left. I'm not looking to the left. I just don't see the right. What if you're sitting with a couple of people and the person on your right you don't even know is there? I'm only looking at the left. And the guy finally says, hey, how come you're ignoring me? I'm over here as well. And I say, I don't see you. What are you talking about? I don't see you. I don't see you. You're in my right homonymous hemianopsia. So I'm only looking at the left. That's why it's said that the eyes deviate to the side of the lesion. I cut the left, I can't see the right. If I can't see the right, I look to the left. If I can't see the right side of each visual field, I look to the left. That's why it's said that the eyes will look at the side of the lesion. If I can't see the right, I look at the left. Where's the lesion? On the left. I'm losing half of my world in each eye if I have a stroke. The middle cerebral artery, I lose half of the motor function. I lose half of the sensory function. I lose half of the ocular function. And if I have a left dominant person, which is 90% of the population is right-handed, left dominant hemisphere, right-handed people, that means that I also develop an aphasia. An aphasia. Now, an aphasia means that I lose the ability to perceive speech. I lose the ability to perceive or speak. I can't hear what you're saying, you can't hear what I'm saying. So what ends up happening is that you lose the ability to perceive speech and communication. And that's with the middle cerebral artery. Now, it is possible to have a very small part of this in what they call a lacunar infarct. A lacoon is an expensive word for lake, and it just basically means small stroke, small infarct. Small infarct. Middle cerebral artery is a large vessel. Middle cerebral artery, I lose contralateral motor, contralateral sensory, contralateral hemianopsia, but the eye looks towards the lesion. Left-sided stroke, right weak, right numb, right hemianopsia, eyes look towards the left. I could have a small lacunar infarct that does just one of them, just motor, just motor. Now, let's look at the other syndromes. Now these syndromes of these three things of the Weber, the Benedict, and the Wallenberg syndrome. These are just saying, well, of the posterior cerebral artery, what if we break up the posterior cerebral artery into different parts? And basically the bottom line is when you see contralateral and ipsi, that's these syndromes of the branches of the posterior cerebral artery. Contralateral and ipsi. So here we see contralateral weakness. On the other hand, you also see ipsilateral third cranial nerve palsy. Contralateral weakness, ipsilateral third cranial nerve palsy, a Weber syndrome. Now on to the next slide here, Benedict and Wallenberg. The contralateral ipsi, contralateral ipsi. Contralateral and ipsi, when you see this combined contralateral and ipsi, it means little branch of the posterior cerebral artery. Benedict syndrome, contralateral ataxia, and ipsilateral third cranial nerve palsy. And you say, how can you have contralateral ataxia? I thought ataxia was a bilateral thing. And the answer is no. What you could have is if I have a stroke on the left, my eye is out on the left, but on the other side, my finger to nose is screwed up on the contralateral side, finger to nose. And on the ipsilateral side, I'm good. So I can give you the finger on one side, and on the other side, I'm ataxic. So healed the shin, the same thing. Healed the shin abnormal on one side, healed the shin normal on the other. So there are certain findings. Ready? Rapid alternating movements. On one side, and on the other side, boom, 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 boom. So you can have a contralateral ataxia. Now, while we're on that subject of the ataxia story, we might as well say that things here. On the issue of ataxia, why do we need finger to nose? Why do we need that and to have heel to shin? Why do we have to have finger to nose and heel to shin? Why do we have to have rapid alternating movements, dysdiadokinesis? Why do we have to have that and Romberg? Remember our Romberg sign. Our Romberg sign is that there's two inputs to keep us upright. My visual receptivity to my cerebellum, out to my muscles, and I stay upright. My proprioceptors from my leg, up my posterior column, to my cerebellum, back down to my muscles. Eyes control the muscles, proprioceptors control the muscles. Two inputs, one from the eye, one from the spinal cord. A Romberg is this. I close my eyes, I've lost one of the inputs. I'm dependent upon the posterior column. I have two inputs that keep me upright. My eyes to cerebellum to motor, I'm upright. Proprioceptors up the posterior column to the cerebellum, back to motor. But what if I have a spinal cord lesion? Then the only thing that's keeping me upright is my visual cues. If my spinal cord is gone, I need visual cues. So that means that a guy who's got a spinal cord lesion, he closes his eyes, he wobbles and he falls over. If your posterior column is intact, like mine is, I can close my eye. Oh, sorry. I can close my eyes in the posterior column and I can keep it in balance because I can feel my proprioceptors. If I wasn't having, every day when I get up, I'm grateful for my posterior column. Aren't you? Because I know I can close my eyes and stay upright. But if you lose your posterior column, you fall over. That's a Romberg. Why do you need all these different things? Rapid alternating movements, gait, ataxia. Romberg, heel to shin, finger to nose. Because the cerebellum in ataxia. The cerebellum is very complex. The cerebellum is very complex. And each of these things tests a different part of the cerebellar anatomy. And anybody who tells you about the different parts, you should run away from immediately, because don't memorize it. It's saying that you can have a normal finger to nose and an abnormal heel to shin. You could have a normal dysdiadokinesis and have an abnormal Romberg. It means that you would have to do several versions of cerebellar testing. The gait, the Romberg, the rapid alternating movements, the rub the stomach and pat the head thing, and you can have normals on half of them and abnormals in only one or two. because each of these tests a different piece of the cerebellum. Now that's good, because that means if you screw up your brain, you have a lot of redundant systems to keep you intact. You wouldn't want just one system, then you screw it up and you can't even stand up. Try getting to work in the morning if you can't get up. So therefore, each of these things a different measure of cerebellar function. Now back to our slide on the posterior circulation. Wallenberg, probably of any of them, the single most important one. Pica means the posterior inferior cerebellar artery. PCA means posterior cerebral artery. Posterior cerebral artery. PCA is posterior cerebral artery. Pica, posterior inferior cerebellar artery. That's ipsilateral facial sensory loss and contralateral body sensory loss. Half my face, I can't feel half my face. I got dysarthria and dysphagia and a Horner's. And remember the Horner's syndrome, a Horner's syndrome is meiosis, anhidrosis, anatosis, meiosis, anhidrosis, anatosis. Pica, a Wallenberg syndrome. Pica, a Wallenberg syndrome. Posterior inferior cerebellar artery. I lose half my face for sensory and the other half of my body's for sensory. I develop vertigo and ataxia because what's the C stand for? Cerebellar artery. Posterior inferior cerebellar artery. So why do I get my ataxia? Why do I get these vertigo? Because I've lost a cerebellar artery. So therefore, the most important is the Wallenberg. Now, in terms of our testing for a person who's had a stroke, let's look at a case here and say, okay, you know what? We have a person who is a 56-year-old person who comes in with weakness of his arm and his leg for the last 2 hours. Weakness of his arm and his leg for the last 2 hours. Now, 56 is young to have a stroke. So if you're 56 and you have a stroke, you probably have a history of diabetes and hypertension. Diabetes, hypertension, hyperlipidemia. Diabetes, hypertension, and hyperlipidemia. If you're 56 and you have a stroke, you probably had some bad metabolic thing. A person without diabetes, hypertension, hyperlipidemia, the risk factors for coronary artery disease are essentially the same as the risk factors for a stroke. Diabetes, hypertension, hyperlipidemia. The other risk is tobacco use. Tobacco equals death. So these are the risks. They're the same as for coronary artery disease. 56-year-old guy comes in with weakness of his arm and his leg for the last 2 hours. Sudden change in a neurological function. Might be sensory, might not, doesn't matter. Might be homonymous hemianopsia, but you know what? People don't know that they have a homonymous hemianopsia. They just don't see part of their world. Did you know that people can miss seeing large parts of their world and not know it? Amazing. That means we need other people to know about the things we don't see. How interesting. We can't know what we don't see unless somebody tells us. Wow. So people do not come in and say, I have a homonymous hemianopsia. I was testing my visual fields at home, and I noticed that I haven't looked at my husband for years. And I thought I just didn't like him. It turns out he's been in my homonymous hemianopsia. You could use that for part of your family that you haven't seen for a while. Listen, Mom, it's not that I don't like you. It's just I think that I have a homonymous hemianopsia, and I just haven't been able to see you or perceive you for a long time. But now I'm better. You can use that for relationships. Say, it's not my fault. It's simply a stroke. Say? So the person comes in with 2 hours of weakness of the arm and the leg. What's the best initial diagnostic test? This is our next slide. Our slide here, it says, What's the best initial test? And the answer is CT. CT. The CT scan. After how long does it take for blood to become visible on a CT scan? How long after does it take for blood to be visible on a CT scan? How long does it take for blood to become visible on a CT scan? How long does it take for blood to become visible on a CT scan? How long does it take for blood to become visible on a CT scan? The answer is immediately, right now, instant, now. Blood, instant, now, right away. No, so hemorrhagic, the 20% that are hemorrhagic are visible instantly. The non-hemorrhagic is another way of saying ischemic. Takes 3 to 4 days, at least 2 days, usually 3 to 4 days. Now, MRI can detect greater than 90 to 95% within 1 day. Why not do an MRI first? And the answer is that, first of all, MRI is not as easily available as CT. Second of all, instantaneously when a person comes with a stroke, what are we interested in first? Oh, you got blood in your brain, man? What are we interested in first? Do you have blood in your brain, man? Do you have blood in your brain? Do you have blood in your brain? What are we interested in first? You got blood in your brain? Because the therapies are largely based on anticoagulation. So the reason why CT, ready? Here's the question. What test would you do first? CT. Here's the next question. What is the most accurate test? MRI. What would you do? CT. CT or give aspirin? CT. You don't want to give aspirin to someone who's got a hemorrhagic stroke. What would you do first? Up to how long is thrombolytics indicated for after a stroke? 3 hours after a stroke, 3 hours after a stroke, 3 hours after a stroke. So what would you do first? TPA or CT? CT. Because if you gave thrombolytics to someone who's just had a hemorrhagic stroke, you just did something called physician-assisted suicide. So if you give TPA to a person who's had a hemorrhagic stroke, you may now join the Dr. Kevorkian School of Medicine, because they are dead, dead, dead. You just turn the brain into tomato soup. You ready? The first thing in acute stroke, CT. Why, if MRI is more accurate? Because we're excluding blood. Why are we excluding blood? Under 3 hours TPA. Under 3 hours TPA. Under 3 hours TPA. What percentage of people get in there within 3 hours? You know what percentage get within 3 hours within a stroke? About 15%. TPA, about 15%. You know why only 15%? Because when somebody feels numb, contralateral sensory loss, it's kind of like saying, when did you first start feeling numb? How long have you noticed that you didn't feel anything? It's like psychotherapy. It's like testing for depression. When did you first start noticing that you have decreased sensation? When did you first start noticing that you don't feel enough? Well, people don't get woken up out of the middle of bed at night by just feeling nothing. You see, chest pain and a myocardial infarction wakes you up out of sleep. So you get to the emergency room. Chest pain that feels crushing, squeezing like a belt or an elephant sitting on your chest gets you to go, man, I'm not staying here. I'm leaving this videotape right now. Excuse me. Oh, I got chest pain. I'm out of here. But if you're sitting still right now in that chair, how would you really know if your left leg was weak? You're not walking. Also, if you're asleep and you get one of those weird posterior things, when would you notice that you had ataxia? Doing a lot of finger to nose, heel to shin in the middle of the night? Doing a lot of Romberg? Testing your Romberg in the middle of the night? I don't think so. Testing rapid alternating movements in the middle of the night? Maybe. Less than 15% come within 3 hours. Why? Weakness? If you're sitting still, you don't even know whether you have a stroke of your left leg. Really? Did you try and walk? And if you have arm weakness, unless you're walking on your hands, many people don't notice that for hours. Isolated left arm weakness, I'm writing with my right hand. Really? How long would you go on before you noticed that your right arm was weak? Are you powerlifting today? Hey man, I could usually curl 80, but I couldn't curl but 10 now. Well, you don't notice. You're not walking on your arms. That's why less than 15% come within 3 hours of a stroke, because chest pain wakes you up out of sleep, is very uncomfortable, feels like a sore Charlie horse. Boom, like you've been punched. Get to the emergency ward. But stroke, weak, numb, tingly. Americans are very sedentary. People can go for years. You can go for like the entire NFL season before you even notice that you were paralyzed. What's the difference? Okay? So the whole point is, stroke, rule out hemorrhagic. Stroke, MRI is the most accurate. Stroke, what are we going to do? Let's look at this picture here. It's a very nice picture. This is a picture of an embolic stroke to the brain, of the middle cerebral artery pattern of distribution. This is hemorrhagic or not hemorrhagic? And the answer is this is not hemorrhagic. Blood appears white. Blood appears white. Blood appears white. Well, how come that this is not blood then? Because that is called choroid plexus. These little white dots is called choroid plexus. And choroid plexus is natural to be a little bit white. This is an infarction. It's edema surrounding infarction. These two things are choroid plexus, and they're naturally a little bit white because of the blood passing through them. Middle cerebral artery. This person is going to be weak on the left-hand side. Sensory loss on the left-hand side. Left homonymous hemianopsia, the eyes are going to be deviated to the right. This person has an embolic stroke. What's the next best step in the management of this patient? The next slide shows this, is that you will use TPA as the best initial thing. You will use TPA as the best initial thing if you have come within 3 hours. TPA is indicated if you have come with less than 3 hours since the onset of your stroke and you don't have a contraindication. Contraindications are, hey man, I bled in my brain last year. Any bleeding in the brain in the past? No TPA. You can't. You'll make them hemorrhagic. You'll kill them. Second thing is, I had aortic valve surgery in the last week. No, you can't give TPA. You'll make them bleed. A major surgery within the last 14 days. Major. It has to be something that could bleed and hurt them. I got very severe hypertension. You know what happens if you get very severe hypertension? You give TPA, it weakens some little blood vessels, and boom, their head explodes. It's like a fembot. Boom! High PT, low platelets, coagulopathy. You can't give it to a coagulopathy. You'll make them bleed. Very severe hypertension. You'll make them bleed. Head trauma, head tumor, head bleeding. Trauma, tumor, bleeding. Trauma, tumor, bleeding. Anytime? No TPA, no thrombolytics. Well, what happens if the person comes and they're more than 3 hours? That's 85%. Remember, 85% of people are coming at more than 3 hours. What would you do first in the treatment of this patient? 56, his CT scan is negative. If you notice that it says hemorrhagic, you're done. There's nothing you can do. Can't drain it out, you drain out the blood, it'll bleed some more. You can't give aspirin, you can't give TPA, you can't give clopidogrel, you can't give dipyridamol, you can't give warfarin, okay, nothing. What if they come, remember, only 15% come within the 3 hours. What do you do if they come after the 3 hours and they're the 85% of people who come after 3 hours? What if you do if they're the 85% who come after 3 hours? What do you do if they're that 85% who come after 3 hours? And the answer is, what you do is you give them an aspirin. You give them an aspirin. What does the aspirin do for the current stroke? Not much of anything. What it does is prevent the next stroke. Ready? Next step. That's the 76. The 86 is like this. A 56-year-old guy comes. He has a new stroke while on aspirin. He's got a new stroke while on aspirin. He's got a new stroke while on aspirin. New stroke while on aspirin. You have two choices. You could add dipyridamol, or you can switch to clopidogrel. Now you'll notice I'm not saying Plavix because Dr. Fisher is not an advertisement for drug companies. Okay? You might say, well, why not add clopidogrel? Which of these is better? Can't say. The study has not been done. Adding dipridamole or switching to clopidogrel, both of these are considered about the same. Adding or switching. Now, let's make up the story for the very controversial subject called when are you going to answer heparin? Heparin use is as close to me saying never as it's ever been. I am this close to saying never. So you'll notice that the notes are very carefully worded because we'd really like to say it's never indicated. The problem with heparin is that it causes you to bleed in your brain. The problem with heparin is it causes hemorrhagic strokes. The problem with heparin is it's never been clearly shown to lower mortality and definitely causes hemorrhage. The problem with heparin is that it doesn't open arteries. It only prevents them from closing up, but there's so much bleeding that we've come to the conclusion that the only potential benefits of heparin might be if somebody is having atrial fibrillation and a clot right now, or is having thrombosis of their basilar artery, in which the basilar artery is actively narrowing at this moment, and you're giving the heparin to prevent the basilar artery, which branches into the vertebrals. They're giving the basilar artery is actively thrombosing now, and you give heparin to prevent that basilar artery from actively thrombosing right now. Atrial fibrillation, if you have a clot. Basilar artery. Another therapy to consider is the drug called ticlopidine. Ticlopidine is very clear for us because ticlopidine is always wrong. Ticlopidine is always wrong because of adverse effects. Ticlopidine is always wrong unless the question says, which of the following therapies is most likely to cause neutropenia? If it says, which of the following is most likely to cause white cell bone marrow dysfunction or TTP, then ticlopidine is the answer. But unless it says, which of the following is most likely to screw you up, the answer is not ticlopidine. Ticlopidine is only the answer for adverse effects. Ticlopidine has essentially been completely replaced by clopidogrel. In terms of efficacy, ticlopidine adds nothing to clopidogrel. In terms of adverse effects, ticlopidine adds enormous things to clopidogrel. Heparin is used for atrial fibrillation and for basilar artery strokes. Let's go to the next slide. This is the hardest thing here. Remember, your question has to be clear. See, no clear benefit due to risk of bleeding, acute thrombosis. Most likely, step 2 will avoid the subject altogether or make your question very clear. If it's less than 3 hours, heparin will be a wrong choice. I will tell you that I predict that there is a 90% likelihood that when heparin is in your answer, it's there as a distractor to make sure you're not an idiot who chooses it. I wish I could say, like ticlopidine, never, but I can't because of a thing called facts. However, 90% of the time, heparin should be a distractor. Less than 3 hours? Aspirin, TPA, heparin, clopidogrel, ticlopidine. The answer is TPA. More than 3 hours? Aspirin, clopidogrel, heparin, ticlopidine, TPA. Aspirin. More than 3 hours and you're on aspirin. Dipridamole, clopidogrel, ticlopidine, heparin. Well, dipridamole or clopidogrel. Heparin should be a distractor. And warfarin has only one indication as well. Warfarin is only going to be your answer. Warfarin is only going to be your answer in one special circumstance. Warfarin is only going to be your answer in someone who has chronic atrial fibrillation. Chronic atrial fibrillation, long-term anticoagulation. Warfarin has no acute place in management. Warfarin has no acute place in management. You have chronic AFib. What does chronic mean for AFib? Chronic means greater than 2 days. Greater than 2 days of AFib. I'm going to anticoagulate you to an INR of 2 to 3. Warfarin has no place in acute management. Let's look at our last slide. Aspirin, first-line treatment for secondary prevention. That word secondary prevention is difficult for people. Primary prevention means this. You never had a stroke before. What do I give you to prevent your first stroke? Secondary prevention is this. You've had a stroke. What do I give to prevent your next stroke? You've had a stroke. What am I going to give you to prevent your next stroke? That's what we mean by secondary prevention. Secondary prevention. What do we do to prevent the next stroke? Aspirin's number 1. And then either dipridamol or clopidogrel later on. Now, the answer is clear if you have an aspirin allergy. If you have a clear aspirin allergy, it's clopidogrel right from the beginning, as it is in the coronaries too. Clear aspirin allergy, clopidogrel from the beginning. So let's look at our therapeutics for stroke. The first thing in therapeutics, less than 3 hours, TPA, provided you're not hemorrhagic. More than 3 hours, aspirin. Already on aspirin, either switch it to clopidogrel or add dipridamol. When do I answer ticlopidine? Never, unless they want you to know how to kill people with neutropenia, which is possible. When do I answer heparin? I would never purposely give heparin to anybody who had a stroke. However, I would really like you to know that heparin is not clearly a benefit in mortality. When do I use warfarin? Never acutely, to prevent strokes from AFib in the long term. To prevent strokes from AFib in the long term. In this method, you take all the answers and you say, here's a clear case. If you start from the cases, there's a million cases. I can make up 300 cases of stroke. But you know what? No matter which case of stroke you have, it's got to look like one of those answers. It's got to look like TPA, aspirin, dipridamol, clopidogrel. Warfarin maybe. You may be able to make 50 cases of stroke, but you don't have 50 answers. There's only 3 or 4 good treatments. So let's do this thinking of also what are we going to do to evaluate a patient who has had a stroke. The person has had a stroke. They've come in and they've had a stroke. Sudden weakness, sudden weakness, sudden weakness, numbness, weakness, 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 numbness, weakness, numbness, visual, weakness, numbness, visual. The first thing to do is a CT. The CT scan shows blood. And the answer is nothing to do, really. Maybe you'll do surgery. Maybe. Maybe surgery. Most likely, nothing you can do. That's it. You're done. That sucks, right? Next, the CT scan is negative because it's a non-hemorrhagic stroke. Non-hemorrhagic stroke. You do the MRI tomorrow, repeat the CT in 3 days. MRI tomorrow, repeat the CT scan in 3 days. Okay? If it's less than 3 hours, the answer is TPA. If it's more than 3 hours and the person is not on aspirin, aspirin. You've got to add aspirin. If it's more than 3 hours and the person is already on aspirin, then the answer is either to add dipyridamol or to switch to clopidogrel. Ticlopidine is always wrong, and heparin is rarely used. AFib, basilar artery thrombosis, very unusual. Very unusual. No clear benefit. And that's all of strokes. Now the next thing is this. I know you had a stroke, and I'm sorry you had a stroke, but where'd it come from? Where'd it come from? Number one, what diagnostic tests should everybody get? Where do they come from, these strokes? Where do the emboli come from? One is an echocardiogram. So everybody should get an echo. If the echo shows a clot, you're going to go on warfarin. If the echo shows a vegetation, you might get cardiac surgery and get that vegetation cut out of there. If the echo shows mitral stenosis, you might get balloon valvotomy. You might get your valve ballooned. But we're looking at that heart to see the source of it. you get an EKG because you're looking for AFib. If there's atrial fibrillation, you're going to give warfarin in the long term to an INR of 2 to 3. If you have a deep venous thrombosis, what is the INR? 2 to 3. If you have a pulmonary embolus, what's the INR? 2 to 3. If you have a person who has almost any clot anywhere, INR, international normalized ratio, 2 to 3. What is the only thing in which the INR goes above 2 to 3? The only thing above 2 to 3 is a metal valve, metallic valve, metal valve. Goes 3.5 to 4, 3 to 4, 3 to 4, 2.5 to 4, 3 to 4. You're going to do an EKG. If the EKG does not show anything, you either do telemetry monitoring or a Holter monitor, again to look for atrial fibrillation. What other test should everybody get? The answer is, in general, everybody should get a carotid duplex. Carotid duplex. Duplex ultrasonogram. Now here's a little fast one. You got to be careful what I'm going to say now. Okay, you ready? If there's greater than 70% stenosis and a stroke, you are going to do carotid endarterectomy. Because it's very clear, what is the clearest indication for carotid endarterectomy? The clearest indication for carotid endarterectomy is symptoms in greater than 70% stenosis. The clearest indication for carotid endarterectomy is a symptomatic stroke in greater than 70%. That is very clear. Step 2 is not going to torture poor little senior medical student type of people with what should you do for an asymptomatic carotid stenosis of 49.5%. Not clear. Not clear. Symptomatic with 50.001%. Not clear. Not clear. What should we do about angioplasty in the carotid? Not clear yet. Not clear. Not clear. Carotid stenting. Not clear. Not clear. Carotid stenting, carotid angioplasty, not clear. Now the great thing about these DVDs is that if a year from now it becomes clear, this section will get refilmed. And we'll change it. We'll take out this clip and we'll put it in. But right now, remember, step 2 can only ask you something that's clear. What do they want you to know? Cyclopidine sucks. It causes neutropenia and TTP. What do they want you to know? Heparin is almost never used. It makes you bleed. What do they want you to know? 70% stenosis or greater and a stroke means an endarterectomy. Greater than 60% with no symptoms, you can do an endarterectomy, but interestingly enough, it's only been proved to be a benefit in men. That's only been proved to be a benefit in men. Now, I have a friend of mine who got very upset about this. Oh, so you guys are keeping all the endarterectomies to yourself, huh? You're discriminating against women. You're not allowing women to have an endarterectomy. And there was kind of a misunderstanding, because really the answer is this: men have more strokes. Okay, so the thing is, greater than 60% stenosis in men only, and the reason for that is that men have a higher risk of stroke. If the risk of mortality for an endarterectomy is 2 or 3%, and the risk of mortality from the stroke is only 2%, why put them through the endarterectomy? Men have a higher risk of fatal stroke, so it makes it worth the trip of the endarterectomy. Now, here's the one last subject in terms of testing. What would you do different if someone is young? And young, of course, means under 50. If you have no risk factors. Less than 45, less than 50. What would you do if somebody is young and having a stroke? What will you do different in the evaluation? What would you do differently in the evaluation of a young person with a stroke? Now, it's true that someone could be 47 and have had diabetes since they were born, hypertension since they're 20, smoke 3 packs of cigarettes, and say, my father died when he was 47. But in a young person with a stroke, you have to look for vasculitis. You have to look for lupus. You have to look for Lyme. You have to look for hypercoagulable states like a factor Leiden mutation, antithrombin deficiency. You have to look for vasculitis, polyarteritis nodosa. In a young person, we're looking for vasculitis and hypercoagulable states. Vasculitis and hypercoagulable states. Vasculitis and hypercoagulable states. Remember, the echo is done to look for clots and to look for valvular heart disease that can be fixed. Aortic stenosis, mitral stenosis. Aortic stenosis, mitral stenosis. Aortics get replaced and mitrals get ballooned. Aortics get replaced and mitrals get ballooned. Aortics get replaced and a mitral get ballooned. The EKG is to show AFib. If the EKG shows AFib, we're going to give warfarin. Telemetry to look for AFib. If there's chronic AFib, we're going to give warfarin to prevent the next stroke. Do you know that for every 100 people who have atrial fibrillation, 6% per year have a stroke? And on warfarin, that rate of stroke goes down to about 2% when you use warfarin. Why do you think that we are using that warfarin? Now, you might say a 4% absolute risk reduction is small, but that's not the way we think of it. We think of it like a 50 to 70% relative risk reduction. You just took down by 2/3 your risk of having a stroke if you have atrial fibrillation. Anticoagulate, rate control and anticoagulate. Rate control and anticoagulate for AFib. Rate control and anticoagulate for AFib. You're doing telemetry to look for AFib. By the way, if your question says atrial flutter, it's the same answers. Atrial flutter, if it's chronic, it's managed with warfarin because it can clot too and sends emboli. Don't be changed by atrial flutter. It can clot too. Symptomatic and 70% surgery. Symptomatic 70 surgery, symptoms surgery 70 surgery symptoms. Asymptomatic? I don't know. Above 60% in asymptomatic in men, endarterectomy. This is the most actively changing area of all neurology. What do I do about that endarterectomy? For right now, the answer is a clear 70% and symptoms, endarterectomy. The others are not clear. People have strokes for the same reason they have myocardial infarction. Diabetes, hypertension, hyperlipidemia, tobacco smoking. Only 15% get there in time to have the TPA. Why? Because it presents with vague symptoms. I'm weak. How would you know if you were weak unless you were lifting something? People lying around in bed don't notice that they can't walk. People lying around in bed don't notice when they're sleeping that they have a sensory abnormality. After 3 hours, which is 85%, aspirin cannot be beaten. If you're on aspirin, add dipridamol or switch to clopidogrel. Ticlopidine causes neutropenia and TTP. Warfarin is only for chronic patients. Heparin is almost never. Echo to find a source of clots. EKG to find a source of clots. Carotid Dopplers to find a source of clots. And in a young person say, well, I don't know, it must be some hypercoagulable state. Protein C, protein S, antithrombin deficiency, factor V Leiden. Protein C, protein S, antithrombin deficiency, factor V Leiden, lupus anticoagulant, antiphospholipid. Antiphospholipid, protein C, protein S, antiphospholipid, protein C, protein S, lupus anticoagulant, most common, factor V Leiden. Lupus, Wegener's granulomatosis, vasculitis, and thrombophilia. That's the end of the CVA section. It is a must-know section for your test. Also, you will like it because you have a chance of having a stroke too. So, right now, who should get aspirin as primary prevention for a stroke? And that is not clear. So if the question says a guy's got hypertension and he's 60, should he get aspirin? Your answer is no at the present time. At the present time, primary prevention with aspirin for a person who has no strokes is not indicated, not yet. Because remember, some people will become hemorrhagic. Isn't it a wonderful thing to learn so much in such a short period of time? Do you feel good about yourself? Did you feel good about how much you learned today? Can we take a moment to feel good for a second? Why do angels fly? Oh, because they take themselves lightly.